Hello guys, I'm Dr. Ranjan, your pharmacology faculty at Marrow. And guys, today in this session, we're going to discuss the recall MCQs which have been asked in the INI-CET recently conducted in the month of November 2024. And the MCQs were moderate, some were difficult, as it always happens in the INI-CET exam. So let us see what are the questions that have been asked. Now, let us begin with the first question. And to begin with, we're beginning with a numerical. A young female weighing 46 kilograms on digoxin with a volume of distribution of 6 liter per kg. Clearance is 4.6 liter per hour. Calculate the half-life of digoxin, right? So this is a direct MCQ that has been asked upon the formula for T half, right? So whenever I say half-life, T half, a formula that we use is 0.693 into volume of distribution by clearance, right? And if you remember in my lectures, I've told you time and again that for calculation purpose in the exam, so that it is quick, rather round it off to 0.7. So let us see what would be the volume of distribution. See, so the volume of distribution is 6 liter per kg and total VD is 46 kg. So total VD would be 46 into 6, right? Total VD would be 46 into 6. Clearance is 4.6. And that we have to multiply with the number 0.7, right? Now, if you do the mathematics, the total number that comes here is 42 hours. So you can do the multiplication and it would come around 42 hours. And so the answer here, option A, B, C, D, C is the right answer. So this is an easy MCQ and only if you can do a little bit of mathematics, right? It's not a difficult one. Now moving on to the next MCQ, which is a plum direct drug of choice. I had been telling you this in my lectures that keep revising 5 drug of choice every day, right? Drug of choice for fasciola hepatica. I've told you this, that albendazole can be effective against nematodes and cystodes, but it is not effective against trematodes. Against one trematode, that is Fasciola hepatica, I use triclarbendazole, right? All other trematodes, I go for praziquantel. So it's a direct MCQ. There is nothing much more to tell here about. All right, now this is a long MCQ, but the answer is easy. Look how. A 60-year-old patient, known case of hypertension and diabetes, and underwent PCI stent placement for an STEMI last year. Is currently on 3 drugs, aspirin, metoprolol, and atorvastatin. He comes for follow-up and his lipid profile is as follows. Cholesterol is raised, LDL is raised, triglycerides is raised, HDL is normal. So which drugs can be added based on his lipid profile? Now see, here, despite giving atorvastatin, and I assume the maximal possible dose, LDL is still high, which means here is a patient of ASCVD, atherosclerosis cardiovascular disease, that is MI. And in ASCVD, our main aim is to decrease LDL and not triglycerides. So in other words, they're asking which of the following drugs here they can decrease LDL or they're used to decrease LDL. So do I use estimab to decrease LDL? Yes, I use. Do I use evolocumab to decrease LDL? Yes, I do use. Do I use gemfibrozil to decrease LDL? No. It is a fibrate which is used to decrease triglycerides, right? And bempedoic acid, yes, I do use bempedoic acid to decrease LDL, right? So these are 3 drugs, 1, 2, and 4. So let us see where this 1, 2, and 4. Yeah, option A, 1, 2, and 4. This is the right answer. So again, I'm saying this is not a difficult one. If you've understood the concept, I've taught you this, which are the drugs used to decrease LDL and which drugs are used to decrease triglycerides, right? Now moving on, which of the following drugs is not given in uncomplicated malaria, right? So I don't know if this was the MCQ or was it multiple options correct? I don't know. But the options, look at the options and you'll understand what I'm trying to say. Option A, chloroquine, B, primaquine, C, artemether, D, sulfadoxine, pyrimethamine. Now, as far as I know, pharmacology, all of these drugs can be used. All of the drugs can be used in uncomplicated malaria. Chloroquine can be used. Artemether can be used with lumefantrine. Sulfadoxine, pyrimethamine can be used. So they're used for treatment of malaria, whereas primaquine is used for prevention of relapse of malaria. But here, the MCQ is not asking about treatment, right? As if it were asking that which of the following drug is not used in treatment of malaria, then I could have gone for primaquine, right? But which of the following drug is not given in uncomplicated malaria? See, English language plays a very important role on what they had asked. So per se, symptomatic treatment. Suppose the MCQ would have been, which of the following drug is not used for symptomatic treatment of uncomplicated malaria? Then my answer could have been primaquine, because it is not used for symptomatic treatment. Rather, it is used to prevent relapse. So I don't know what was exactly the MCQ, but if this was the exact language of the MCQ, I cannot find an answer to this, guys. Right? So the recalls are sometimes biased, right, and are not correct. Anyways, moving on to the next drug that binds to CD4 and has action on both CCR5 and CXCR4 tropic HIV infection. So basically, it is asking which is a CD4 inhibitor. There is only one drug that inhibits CD4, and it's a MAB, ibalizumab. So all of you know that, right? Maraviroc, Vicariviroc, these are CCR5 inhibitors. So this cannot be the answer. Elbitagravir tegra, it is an integrase inhibitor, not an answer. First Prenavir, and I've told you Navir are protease inhibitors. So all of these drugs, they do not bind to CD4. The only drug that binds to CD4 is ibalizumab, and it's a drug that is given by IV route, intravenous route. So it's again a pretty direct MCQ, directly asked, right? There's nothing difficult in this question. All right, now this one is a difficult one. Drug acting on sodium channel and potentiating slow sodium inactivation. Right, so this is an MCQ which has been picked directly from a textbook of pharmacology called as Goodman-Gilman, where there is a line, right? Now, slow activation or inactivation of sodium channel, here the answer is lacosamide. And slow inactivation of sodium channel is the reason why what happens is I prefer it in partial seizure, because slow inactivation of sodium channel is why it blocks repetitive firing, the repetitive firing of the neurons. So the sustained repeating firing of the neurons is what is responsible for partial seizure. So lacosamide is a good drug for partial seizure, and that's it, guys. In lacosamide, phenytoin, lamotrigine, topiramate, they have no effect on slow inactivation of sodium channel. So again, now such MCQs are not rank deciding MCQs, right? Because nobody knows the answer, because you can pick up one line from any textbook, make an MCQ. All right, now moving on. Inhibitors of poly-ADP ribase polymerase are approved for BRCA positive breast cancer. Which of the following drug is used? Look at the options: palbociclib, rucaparib, regorafenib, and vandetanib. Now, here the answer is rucaparib. And how I've taught you this, that whenever there is ib means inhibitor of PARP. So PARP inhibitor, PAR-IBs are PARP inhibitor. As simple as that. What is palbociclib? IB means inhibitor, cis means CDK, cyclin dependent kinase, cis for cyclin, CDK4 and 6 inhibitor. It is also used in breast cancer, by the way, right? Regorafenib, IB inhibitor of RAF. RAF has been taken from BRAF. So it is a BRAF inhibitor used in malignant melanoma. And vandetanib is an inhibitor of VEGFR tyrosine kinase. So here the answer is rucaparib, and again, this is not a difficult MCQ, and I have taught you this in Marrow, how to dissect the name of the drugs and get to the right answer, right? Now moving on to the next question, guys. A known case of ulcerative colitis is not responding to anti-TNF alpha agent. Which JAK inhibitor is preferred in moderate to severe ulcerative colitis? Vedolizumab, tofacitinib, leflunomide, ozanimod. Now if I look at all of these, the answer here is the only JAK inhibitor, Janus kinase inhibitor. If you don't know anything, if you know that the tyrosine kinase inhibitor, they end as IB means inhibitor, and tyrosine kinase, T for tyrosine kinase, is inhibitor, tyrosine kinase inhibitor. So if you know this much, you could have answered this, that tofacitinib is the only JAK inhibitor. So again, it is not a difficult MCQ, right? So JAK inhibitors, they are oral drugs, and 3 JAK inhibitors, you can remember BUT, but if I give TNF alpha agent, but the patient does not respond, that is the but, then I use drugs like baricitinib, U for upadacitinib, T for tofacitinib. So these are some of the examples of JAK inhibitors. So again, as I have said, right, trying to find out how drugs are named nowadays, the drug companies are very smart. So they name a drug by a particular, thing, keeping in mind its mechanism. So as here, in case, in PARIB, you would have answer in tofacitinib, you could have answered just by looking at the name of the drug. All right, correctly matched antidote with toxicity. Look at this, or is the easiest MCQ probably in this exam. Organophosphorus 5-segment is wrong. Atropine would be the antidote, right? Atropine for organophosphate, atropine antidote is L-carnitine, wrong. Atropine antidote is 5-segment, right? L-carnitine is rather an antidote for valproate-induced hepatotoxicity. Benzodiazepine flumazenil, right? This is the correct answer. Arsenic diferoxamine, again, this is not correct. Desferoxamine is an iron chelating agent. So C is correct, and this is again not a difficult MCQ. All right, which of the following will lead to decrease in diastolic blood pressure? So there is some physiology here. Systemic infusion of alpha blocker, right? So this can be a possible answer. Let us see. Systemic infusion of smooth muscle relaxant, no. Loss of lumbar sympathetic outflow, yes, it can cause. And systemic infusion of beta-1 adrenergic agonist, it would rather increase cardiac contraction output. It has nothing to do with diastolic blood pressure, because diastolic blood pressure is much more related to the vascular tone, right? Now see, whenever I give alpha blocker, they decrease diastolic blood pressure, but the decrease is minimal. It's not that significant, but a significant decrease in diastolic blood pressure would be seen because of a loss of lumbar sympathetic outflow. Suppose there is spinal cord trauma, and because of spinal cord trauma, sympathetic nervous system is not able to control the cardiovascular system. That would lead to vasodilatation, and that vasodilatation can lead to decrease in diastolic blood pressure, plus there would be postural hypotension, etc. that can be seen. So you can say this is an MCQ from pharma plus physiology. So better answer, guys, here would be C, right? So this is little bit difficult one. Now here, if you would have marked option A, it would be a wrong answer, but I would not say it is a stupid answer, right? It is not a stupid answer. So you have to understand the difference between a wrong answer and a stupid answer. It's a good answer, but it is not the correct answer, right? All right, true treatment for pretomanid, a new drug for TB. All right, look at the options. Let us find out. Given for XDR, TB with bedaquiline and linezolid. No, this is wrong. It is not given for XDR. Rather, it is given for pre-XDR. Pre-XDR, that is MDR plus fluoroquinolone resistance. MDR plus fluoroquinolone resistance is called as pre-XDR, not in XDR, right? Contraindicated in patients on enzyme-inducing drugs. So it is metabolized by microsomal enzymes. So this is a fair contraindication. I should avoid it with enzyme inducers. Act by reactive oxygen species. Let us see. What is pretomanid? There is a pretomanid belongs to a class called as nitroimidazole. So it produces it produces free nitroanion radicals. So it is not reactive oxygen. It is rather reactive nitrogen species, not oxygen, right? So this is again not correct. For resistant malaria, I mean, this is a stupid option. All of you could have ruled out this one, right? So option B is correct, pretomanid. So remember, in India, B-PAL regimens, right? This regimen is called as B-PAL. B-PAL, where I have bedaquiline, pretomanid, linezolid, is for pre-XDR. A new regimen has been approved recently in September, and that is called as B-PAL. M for moxifloxacin, and this is for MDR-TB. This is not for XDR, this is for MDR-TB, because in XDR, I would have resistance to fluoroquinolone, right? So B-PAL is for pre-XDR, and B-PALM, M for moxifloxacin, is for MDR-TB, guys. All right, so that is a new information that you can add on to your notes. Choose the correct option regarding phenytoin. So I think this is what is missing in the question. The options are regarding phenytoin. Acute oral overdose results primarily in cerebellar and vestibular symptoms. So ataxia, so you've talked about this. Ataxia can be seen, diplopia can be seen, dysarthria can be seen. These are cerebellar and vestibular symptoms. And high doses have been associated with marked cerebellar atrophy, right? So this is a correct option. So choose the correct option. Let us see if any other option are correct. High dose causes cardiotoxicity and nephrotoxicity, old and young. This is stupid point. No. The complications can be minimized by administering phenytoin at a rate of less than 250 milligrams of phenytoin sodium equivalents per minute. No, it is not 250. It is rather less than 50. Like more than 50, causes these side effects. So if I give it more than 50, what are the side effects? Let us see. If it is given more than 50, then the patient would develop cardiac arrhythmia and CNS depression, right? So high doses IV would produce arrhythmia and CNS depression. Now look at option D. What it is saying, given to all patients with seizure, regardless of cardiac arrhythmia, hypotension, and or CNS depression. Again, this is wrong, right? So here, the right answer is option A. Acute oral overdose results in cerebral vestibular symptoms, and high doses have been associated with cerebral atrophy. So if there is cerebral and vestibular symptoms with the high doses, acute oral overdosing, then what do I do, guys? I do something called as TDM or therapeutic drug monitoring, and then based upon the plasma concentration, I go for dose adjustment. That is what I do, guys, right? So it's a simple MCQ. Now the last one here, which drug acts on the marked receptor? So this is Indian student GAT inhibition. The marked one was this one. The GAT was marked. GAT is GABA transporter was marked. And they'd asked you which drug acts upon GABA transporter. We have studied about this in marrow. Then the only drug that inhibits GABA transporter. So GABA, IN means inhibits, G means GABA. GABA inhibits what? T4 transporter. So tiagabine is a GABA transporter inhibitor that is used only for treatment of partial seizure, right? So guys, this is all about the INI-CET November 2024. Whatever MCQs were asked, I've tried to discuss all of them quickly, as quick as possible, so that I don't take away a lot of your time for preparation. Now, these MCQs will guide you through how to prepare for the next INI-CET exam, plus some information. Sometimes they are cross-asked in NEET PG as well, right, guys? So those students, it would just my advice to those students who have not done well in INI-CET, please don't lose hope, right? There is still a lot of time for NEET PG, and your fortunes might change drastically. Now, from being non-qualified to getting under 5,000 rank is doable. A lot of people have asked me, sir, I am not qualified in INI-CET, right? So if you're not qualified in INI-CET, ask yourself, what was the reason? Had you completed all the 19 subjects and revision and given adequate number of grand tests, you'll find that something is missing. Either you have not completed the 19 subjects, or you did not have the time to do 3 revisions. You have done just 1 revision, or you have not done a lot of MCQs, or you have not attempted grand test. So find the reason, right? And work on that problem that you have. And gradually you'll see in NEET PG, from even not being qualified, forget about bad rank, even not being qualified, to you can get a good rank under 5,000. So never stop believing in yourself, guys. So that's all. Thank you very much for watching this session. This was Dr. Ranjan, your pharmacology faculty from Marrow, guys. Take care.